Well, welcome to Providence Grand Rounds. This should be a fascinating topic on progressive hearing loss in children by Dr. Betsy Schluge. Before introducing our speaker, we'll review our logistics. So all attendees are muted, and please use the Q&A box to ask questions and share comments. We will monitor the chat as well, but for questions, we prefer that you use the Q&A box. The presentation is being recorded, and it will be posted on the Caregiver Grand Rounds site, where previous Grand Rounds recordings are also available. Next slide. Here is the continuing education information for CME, continuing pharmacy education, and continuing nursing education. And we'll post the number for the CME in the chat as well, so you'll be able to access it later. Next slide. None of the planners or presenters for today's presentation had any financial relationships with commercial interest as our disclosure summary. Next slide. And here are today's learning objectives. At the end of the session, participants will have an increased ability to describe the clinical presentation of Pendred syndrome, review the presentation of vestibular dysfunction, hearing loss in the pediatric population, and discuss treatment and management of hearing loss and vestibular disorders in the pediatric population. And now it's my pleasure to introduce Dr. Betsy Schluge. Dr. Schluge earned her doctoral degree in audiology at Indiana University, speech and hearing department. She's a pediatric audiologist and vestibular specialist at Cadillac Regional Medical Center in Richland, Washington, and has been practicing since 2016. She is passionate about educating the medical community on vestibular disorders in the adult and pediatric population. So we look forward to this presentation and welcome Dr. Schluge. Thank you.
Thank you so much. Like you said, I'll be presenting on enlarged vestibular aqueduct that I'll refer to as EVA just because it's a mouthful. Next slide, please. So an outline, we'll go over EVA associated with Pendred syndrome, looking at the anatomy, clinical characteristics, and diagnosis and management. And then we'll look at a case study together and go over questions. Next slide, please. So what are vestibular aqueducts? So up here you have the normal part of the ear, the inner ear labyrinth system. So it's kind of snail-like. So you have the vestibular system here responsible for balance, and then the cochlear system here responsible for hearing. The aqueduct tunnel leads to the endolymphatic sac. And in the abnormal ear, you have this enlarged diameter leading to the enlarged endolymphatic sac. So this is identified on temporal bone CT scans, so the diameter greater than 1.5 millimeters. And there's not really much known about the role of the endolymphatic sac, although there are theories that abnormal chemical properties are thought to contribute to the cause of hearing loss associated with EVA. Next slide, please. So you have sensory neural hearing loss, and which is an inner ear hearing loss of the cochlea or nerve. 20% of congenital sensory neural hearing loss is associated with an inner ear malformation. And of these, EVA is the most common. EVA is further differentiated into syndromic versus non-syndromic. So with non-syndromic, the patient will present with hearing loss, vestibular dysfunction, and temporal bone abnormalities as identified on CT. So it will show the EVA with or without Mondini, which is it is an underdeveloped cochlea known as cochlear hypoplasia. And then in the syndromic syndromic version, it will include thyroid pathology. Next slide, please. So the theory between EVA and hearing loss is thought to be related to the high pressure system causing destruction of the membranes of the cochlear and vestibular membranes, which leads to hearing loss and vestibular impairment over time. So in the normal ear system, you have two windows that help to progress these pressure waves through the fluid. When you have this enlarged diameter, it acts as a third window. And so it sort of reorganizes this pressure system. And so on audiogram, it can show up as this conductive component. However, the loss is not originating from the middle ear. And I'll have an example of this in the case study. So we call this the false airbone gap. Next slide, please. So clinical characteristics of Pendred syndrome. Vestibular dysfunction should be suspected if, particularly in the syndrome, if the child is meeting developmental milestones, but they're having these intermittent episodes of ataxia or trouble walking. So hearing impairment most often will present as severe to profound, but it can also range from mild to moderate. It will show up as sensorineural in nature, and it can show this false airbone gap. Most of the time it's in both ears, and it can occur congenitally or in the case of this syndrome, it can also occur postlingually. And that's sort of another rarer characteristic of syndromes. Most syndromes with hearing loss occur congenitally. And then the loss can be progressive, fluctuating, or stepwise in nature. So stepwise is the hearing loss is triggered by an event like a head trauma or a high fever. Next slide, please. Diagnosis of Pendred syndrome is going to include audiology results. So the loss that I just described, and then genetic testing will identify a pathological variant of the Pendred gene known as SLC2684. Temporal bone CT imaging will show the EVA and may or may not show the underdeveloped cochlea. And then the deficiency of the medialis is just another cochlear malformation. And then endocrine findings will confirm if this is a syndrome, and that can become apparent after age 10 years. Next slide. Treatment for hearing loss. Hearing aids as soon as possible. As the loss progresses, the child may need cochlear implants. Speech therapy and oral rehab is very important during this foundational stage of speech and language development. And then hearing surveillance every 3 to 6 months if the loss is fluctuating or progressing. Once it stabilizes, then just annually. And so in some cases, vestibular rehabilitation may be beneficial to the child if they are not meeting milestones. And dizziness presents differently in childhood. Obviously, they don't have the words to describe their dizziness, but oftentimes, once they're mobile, parents will kind of describe them as clumsy or running into things. And then the endocrinologist will manage thyroid, and the family will be offered genetic counseling. Next slide, please. So this is a case study of a nearly 5-year-old female who presented to the audiology clinic with a complaint of expressive speech delay. And actually, the ataxia was not part of the referral. This was just something that that was a red flag right away when I started to do her chart review. Next slide, please. So discharge summary, normal or unremarkable pregnancy, labor, delivery. She was born full term, planned C-section. Her APGARs were normal at birth. However, she did fail her newborn hearing screening in both ears at age 2 days old. Her newborn hearing screening retest was completed at age 4 days, and she failed the right ear again and passed the left. And the state confirmed that she was lost to follow-up, which I'm not sure what happened. However, the parents were under the assumption that she had passed both ears. So in a normal sort of process, the baby would have been referred to audiology for diagnostic hearing evaluation. So the state guidelines are that the baby is screened by 1 month of age, diagnosed by 2 months, and treated by 3 months of age. And this is to, we know that the most important foundation for speech and language development is between day 1 of life to 2 years of age. So it's very important to get the child treated as soon as possible. Next slide, please. So I'm going to be looking at her well child visits, and in her first 15 months of life, she's meeting milestones per CDC checklists. So I'm looking at specifically social, language, and movement because hearing loss can affect our social interactions and obviously language. An impaired vestibular system can cause psychological distress and can show up with motor skill development. But everything is looking normal. She is responding to her own name. She's making sounds to express emotion. She is doing a lot of experimenting, a lot of mimicking and copying gestures and sounds. She's got a little stranger danger, but otherwise there aren't any concerns of delay. Next slide, please. So at 16 months of age, she has her first visit to the ER. She presents with a migraine headache. Her parents say that she's been having headache and ataxia since age 12 months, but this is the first time it's been documented. So she has this unsteadiness and gait instability, and physical findings at the ED report nystagmus. But all the imaging is normal CT head scan, normal brain MRI. And also this graphic is meant to convey the stepwise progression of her loss with each of these vertiginous episodes. So she's diagnosed with cerebral ataxia and she's referred to pediatric neurology. And if this had been an adult, they would have also been referred to audiology, especially when the scans and the labs are all normal. You can start to be suspicious of the ear involvement. Next slide, please. So her 18-month well child visit, she's meeting all developmental milestones, and the MCHAT is administered and she is not at high risk for autism. Next slide, please. So a few months later, she's back in the ED. She's presenting with similar symptoms, unsteady gait. She has nystagmus again. She can't hold upright unless she's holding onto her parents. And so differential diagnosis includes migraine this time, and a pediatric neurologist is consulted. So migraine is one of the most common reported causes of dizziness in the pediatric population, 30 to 35%, but not typically with nystagmus. So she's treated as migraine with ibuprofen, which has been shown to be beneficial for acute pain in the pediatric population. And they recommend if she comes back again to complete an EEG. Next slide, please. So 24 months of age, she's 2 years old. She hasn't had any recent episodes of ataxia. There aren't any developmental concerns from the pediatrician or the parents, no behavioral concerns, and she's still on track meeting milestones at age 2. Next slide, please. So 33 months, she's back in the ED again. This time, parents have concerns that she's having a seizure. She had suffered a burn from cooking, and this time her dizziness was categorized as a vasovagal syncope. And they note that it's unlikely a neurological disorder. So stepwise loss likely triggered by these going hand in hand with these vertigo episodes. Her hearing loss is getting worse and worse over time. Next slide, please. So this is when problems start to pop up. Mom has questions about possible speech delay. So this is the visit right after the ED. A lot of red flags. So she's rarely talking. Her speech is unintelligible. She doesn't talk to people at school. Strangers don't understand her, but she doesn't want to talk to strangers anyway. And so they talk about social shyness versus speech delay. And so a speech therapy referral is placed, as well as this like ongoing pediatric neurology referral. So she's nearly 3 at this point. Again, with all these red flags, usually the audiology referral is also placed kind of at the same time as the speech, because you want to rule out any hearing loss that would be the reason for the changes in speech. So she comes back at 36 months and her behavior is starting to be impacted. Obviously, she's getting frustrated because she can't hear and she can't communicate that she can't hear anymore. A speech referral is placed, and because she can't hear, it's looking like she's shy and not wanting to interact. And so no further treatment was recommended, and they advised to have her come back in 6 to 8 months if there were still concerns. Next slide, please. So she is almost 3.5 years old, back in the ER with same symptoms: migraine, gait problem, nausea, vomiting, decreased activity. Still hasn't been seen by a pediatric neurologist at this point. Still no referral to audiology. Next slide, please. So she's back at the pediatrician, 3 years, 10 months. She's following up for speech and social delays. At this point, there are some sort of vague concerns of autism spectrum disorder. She wasn't able to participate in speech therapy. Mom was hopeful that she would sort of take off in her speech and language development because she is meeting all of her other milestones. But she's starting to have concerns as she sort of compares her child to other kids her age, and those delays are becoming more apparent. So at this point, she is referred to the Developmental Center for Speech and Developmental Delays, but still no referral to audiology. And I think these are interesting descriptions to me. So she comes back at 4 years, 7 months of age. Socially, she's cooperating with people her age, kids her age. So she wants to connect. She wants to, play, but she's not playing games because she cannot hear in order to follow the rules to play these games. And she is singing songs from memory. So this is what tells me that her loss is postlingual. So she has this foundation of speech and language probably for the first 2 years of life. And she's probably gone without hearing at this point for over 2 years. And there's still no concern of hearing loss from her parents even. And I think this is another tricky part of the postlingual loss is that, if she has access to visual cues, she can probably guess, fill in the blanks. Routines are sort of expected. She sort of knows what to expect, what they're going to do next. And gross motor skills have not been impacted. So again, guessing, she's lost her hearing around age 2. She has that foundation, but she hasn't added anything to it in over 2 years. But she's finally referred to audiology for an expressive speech delay. Next slide, please. So this is her initial evaluation. Going through the case history with Dad, he says that she passed her newborn hearing screening, but we know she didn't, and somehow that didn't get communicated well enough to the family. He doesn't have any concerns of loss, although he does say that she prefers to watch the television on mute when she's watching TV. And so I thought that was kind of an odd / red flag. So her initial hearing evaluation, she's diagnosed with a flat, moderate to severe hearing loss. So the majority of speech she's not hearing at soft or average conversational speech. So her functional tests show that her middle ear function is normal. So that red circle is the air bone gap, and that's sort of a little piece of evidence that there's some sort of inner ear malformation going on when you have normal middle ear function. And then the graph on the right side at the bottom, OAE, otoacoustic emissions, are a test of the outer hair cell function in the inner ear, the cochlea, and those are abnormal on both sides. So site of lesion, inner ear, both ears. So an ENT referral is placed to determine the etiology of her hearing loss and also for medical clearance for hearing aids to move forward. I recommended imaging comparative to her 2016 imaging and genetic testing. And I noted that her case history suggested her loss had occurred postlingually. So she's connected to resources and she's scheduled for follow-ups. One is her confirmation hearing evaluation to confirm reliability and also to obtain more conclusive results. And then another is to monitor her loss in 3 months. So reviewing everything with her parents, who are very with it supportive parents, we decided to move ahead quickly with hearing aids following that appointment. Next slide, please. So her confirmation hearing evaluation is showing stable thresholds in both ears, just more extensive. And so we know audibility wise what she's not hearing, but I want to know how is she actually processing sound and speech. And because at this point, we don't know if she's mute. There was this suspicion of mutism, or shyness, or an overlay of autism, but regardless, she's nonverbal. So I administer this closed set, age appropriate, what's called WIPI. It's a word identification by picture identification, to understand her processing. And her scores are significantly low. So she gets a 12% and a 16%. And so these low scores are consistent with auditory degradation. So her nerve and the auditory centers in her brain have not been stimulated in what we're guessing is over 2 years. Reliability is great. I review the case with an ENT, and because of the complex nature with the migraine as well, we recommend that she be referred to a pediatric ENT specialist at Seattle Children's Hospital. So a referral is placed. Next slide, please. So treatment, management, and hearing rehabilitation. So 2.5 weeks after she's ID'd, she spit with hearing aids. And 2 weeks after, 2 weeks after her fitting, she's asking to put the hearing aids on, which is just like the greatest indicator that a child is benefiting from these devices. And research recommends at least 10 hours a day, but she's wearing them 11 hours as identified by data logging in her hearing aids. She is increasing vocalization, so she's experimenting with sounds that she's missed out on. She's able to localize and respond to soft speech, and she's paying more attention. Mood-wise, she's still about the same. Her engagement has not increased, and her vocabulary has not increased. 8 weeks from fitting, Dad reports she is putting together 8 to 10 word sentences, which is pretty amazing. And she is communicating she's communicating emotion, and she's participating more in back and forth conversation. So she's highly motivated, and she had this foundation at one point. She lost it, she has it back, and that early foundation really is key to her success, her ongoing practice and success. And she knows that hearing is how she's able to connect in her world. Next slide, please. So this is showing the progression of loss over time. So we have her baseline hearing evaluation, 3 months later, monitoring, looking for progression or fluctuations, but everything is stable. 6 months, you see, I don't know if you can see my mouse. So the circle is the right ear. So you see a drop from this moderately severe range into the profound range. And I had attempted to get some sort of processing in that ear, but she was generally pretty frustrated whenever she had to do speech tests. So the drop in the right ear is a concern. So I have her come back, I think it was a week later, to retest. The right ear improved, but compared to the baseline, there was still a progressive component to it. So here is evidence of both a fluctuating hearing loss, and also a progressive loss in the right ear. Next slide, please. So she finally makes her way to Seattle Children's, sees an otolaryngologist at the Childhood Communication Center. He orders genetic testing and temporal bone CT and places referrals to psychiatry to rule out autism or mutism, speech, oral rehab, audiology, and ophthalmology. to rule out other sort of syndromic symptoms. At her pre-op, imaging comes back positive for bilateral EVA, and she also has the underdeveloped cochlea in both ears. Genetic testing did show mutations of the pendrin gene. She does present with bilateral sensory neural hearing loss and speech delay. And so she does meet the FDA criteria for a cochlear implant on the right ear. Remembering that that was the ear that she initially failed at her newborn hearing screening. So at this point, they've ruled out autism spectrum disorder, mutism, auditory neuropathy, and bacterial meningitis. And then I believe to confirm that it's actually a syndrome, she's monitored by endocrinology. And if a goiter presents, that would indicate a syndrome. So 1 month post-op, she is fit, she is implanted at 6 years, 3 months. And she's doing well with bimodal stimulation. So she wears the hearing aid in the left ear and the cochlear implant in the right ear. And after remapping, she is getting borderline normal responses hearing-wise in the right ear. Next slide, please. So outcomes to date. This is her most recent audiogram at Seattle Children's, looking at the response of the cochlear implant, so she can hear all parts of speech in a borderline normal hearing range. And she's participating very nicely in weekly speech language therapy. Her vocab and syntax is not yet age appropriate. Dad told me that the speech therapist predicted around age 8 years she would sort of even out. But the good news is that with active and routine stimulation from the hearing aid device and the cochlear implant, all those neurological pathways are being stimulated, and her WIPI scores have improved from significantly poor 12 and 16% to 79%. And with family support and her own motivation, she is utilizing bimodal stimulation consistently. And next slide, please. So in conclusion, this is sort of an unfortunate story of the medical system failing this child repeatedly. But I think, I know vestibular disorders in childhood, it is a growing area of research and clinical medicine. And so similar symptoms that occur in adulthood can absolutely occur in childhood. So we need to be aware of how that presents differently in the pediatric population and what the referral routing looks like. And I think there's definitely an opportunity for a multidisciplinary approach. Next slide, please. And if you're interested in sort of a really great, comprehensive and adaptive clinical guide, there is a Boys Town is a big hub for pediatric audiology research, specifically vestibular, and they published the Dizzy Child clinical guide last year. Next slide. So if you have any questions, I'd love to answer them. And if you ever have questions in the future or you want to reach out, please don't hesitate to email me.
Dr. Schluge, thank you for that great presentation and a really interesting case study. The detailed case study was great. I had a few questions. Would you anticipate that she may eventually need a cochlear implant in the left ear as well?
I imagine, although it looks like her left ear has been stable over time, and as long as she's improving and processing in that ear, I think, as long as she's benefiting from a hearing aid, but if it continues to progress, probably a cochlear implant.
And is it known the relative proportion of syndromic versus non-syndromic for the enlarged vestibular aqueduct problems?
I think it's 20%.
Are syndromic?
Yes.
Okay.
But don't quote me on that.
All right. And do you have any speculation about, because earlier in her course she did see speech and language therapists a couple times, and it is kind of surprising that she wasn't referred at an earlier time to audiology, even with the newborn screening that people might have been able to access. I just wondered if you had any thoughts about that.
About
why she wasn't referred to audiology earlier when she was seen by speech as a toddler.
I don't know, because usually we get the referrals are placed at the same time to audiology and speech therapy. We get, anytime there's a question of autism, even ADHD or speech delay, we get referrals to rule out that hearing loss is contributing to that, because sometimes it can look like those things when it's actually hearing loss.
Thanks. And then one other question. I know we have effective ways of treating the hearing loss, and fortunately, developmentally, she seems to be on a great road to recover. But looking into later life even as a young adult or older, with the enlarged vestibular aqueduct, would one, and unless there's another form of treatment for that, would one anticipate that she may have, balance problems and all later in life?
Yeah, so I think, so with the episodic nature of specifically the kind of vertigo that she's having, it's not affecting her overall balance. So you like, it's disrupted and then it returns to this homeostasis, and then it's disrupted and it returns. And so like in the adult population, like Meniere's disease, like vestibular rehab through PT may or may not be beneficial. It's kind of unclear. But as she ages and her other systems start to diminish, she will probably have balance issues, as her vision starts to decline, as her whatever other sort of symptoms develop with age. But I don't think in like childhood or early adulthood. Thanks.
And last question, from what you know, is there any way to associate the migraine headaches that she supposedly went in for, given that they're relatively uncommon in that small a child?
Yeah, that's a very good question. So like I said, the childhood migraine is sort of the basket case, or like, what dizziness gets clumped into during childhood, I think, because we just don't know that much. We're learning more. But in the adult population, they overlap all the time. So you think of vestibular systems and migraine sort of in this Venn diagram presentation, where you can have both symptoms sort of clustered together. And so that would be something I'd be curious about with her. And then also if, you know, it was just the fact that she's spinning so hard that it makes your head hurt. It's hard to really know.
Great. Well, thank you for a really fascinating presentation and case study. And I want to thank all the members of our audience who joined us. And we look forward to seeing you at next week's Providence Grand Rounds.
Thank you so much.
Thank you. Bye-bye.
Bye.